My name is Dr. David Alter. I am a cardiologist and associate professor of medicine at University of Toronto and University Health Network, Toronto Rehabilitation Institute. Journal article is entitled Relationship Between Cardiac Rehabilitation Participation and Health Service Expenditures Within a Universal Healthcare System. And it is published in Mayo Clinic Proceedings. This study sought to look at the link between healthcare costs and cardiac rehabilitation participation. And what we knew going into the study was that cardiac rehabilitation improves survival and in some jurisdictions may have been linked to improvement of healthcare costs, but it was ambiguous. Particularly because we know that upwards of 50%, or in some cases even more, of patients who enroll into cardiac rehab will not complete it. So what we really sought to examine was this relationship between healthcare costs following cardiac rehab and the level of participation. And what we found was that indeed patients who participated and completed cardiac rehabilitation had much lower healthcare costs in the years following their cardiac rehabilitation than those that did not complete or did not participate whatsoever in the program. And healthcare costs were quite tightly linked to participation levels. A secondary finding was that so too was survival. So the greater the level of participation, the greater the long-term survival. So this article, I think, represents a challenge for cardiac rehabilitation. I think on the one hand, we know that cardiac rehabilitation, now it reaffirms that cardiac rehabilitation does have quite significant healthcare expenditure savings to the healthcare system, but it's really contingent on levels of participation. And the challenge is that when we plan our healthcare system, we do so on the anticipated demand. How many patients are we going to be referred? What is the demand and the quote-unquote need based on population, and we kind of resource our cardiac rehabilitation services accordingly. What this shows is that a lot of those resources that we're allocating up front may not be fully realized in terms of their benefits and cost savings. It's only those that really participate and particularly complete the program where one would really realize the savings to the healthcare system. So it poses a challenge. We need to really focus quite heavily on improving those participation levels if indeed we're hoping to make strides in improving the dollars that are being saved from cardiac rehabilitation. Up till now, levels of participation, these metrics of sort of how well people are completing and when are they dropping out, haven't been traditionally thought of as quality metrics, quality measures in cardiac rehabilitation programs. Generally speaking, we assess people up front, their fitness levels, their healthcare knowledge. We look to see how that has improved over time. And in so doing, we've kind of ignored the many people who may be dropping out because we can only measure the after effects of a program among those who show up. So we've always looked at a very skewed sort of subgroup of the populations in cardiac rehabilitation, and from that determined whether it was good or is not good. And I think what this study from a clinical standpoint really highlights is the need to focus much more on who is dropping out, who are we not seeing, who are we not getting those after measures, because it's that group of people that will drive the real benefits of cardiac rehab in the population. If we can even marginally improve that dropout rate, we may be having really quite significant improvements in not only survival, but savings, healthcare dollar savings to our system. We haven't traditionally done that in cardiac rehab measurement, and I think we need to. And I think that is probably the main takeaway. The only other takeaway from a clinical perspective that I would add is that the counter is also very true. In patients who drop out early from a program, really does signify a group of people who are at particularly high risk of dying and who are very, very costly to our healthcare system. And so if a clinical program like cardiac rehab can't get them back, what else can we do in the healthcare system to try and address what we would call from the cardiac rehab the ghost population, the population that drop out that we never see again? That's a very vulnerable, high-cost subgroup that is very important for our healthcare system, and perhaps cardiac rehab can better inform who those patients are so we can target them differently through other ways. The message for patients, I think, by and large, doesn't change. I think cardiac rehabilitation is important in terms of its benefits to their longevity. We've known for a long time cardiac rehabilitation is important for their quality of life, as is exercise and all the components within cardiac rehab. That hasn't changed. What has changed is reaffirmation to patients that really to get the full benefits of the service, you've got to not only show up, but still be batting in the ninth inning and still be present throughout the whole program. And sometimes we may not stress that enough to patients.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.